Welcome to AP2. The thing I like about AP2 is that these are the systems that are really important. We start off AP2 with the cardiovascular system. The cardiovascular system consists of the heart, blood vessels, and blood. This is a good system to start AP2 with because, as with most things in AP2, this is a system that is very important because when it fails, it lands you in the hospital. Even more morbid, often the first symptom of pathology in the heart is sudden death. Pathologies of the heart account for about 30% of all deaths. This is a complex system. There's a lot to cover. We'll go through size and weight, chambers of the heart valves, layers of the heart, the coronary circulation, heart muscle cells, and the conduction system. In almost all cases, the simple knowledge must be built up in order to understand the physiology and pathology of the heart. Notice that things like the heart muscle and the conduction system get particularly deep as we radiate out. This is because control of the rate and strength of the heart is complex and dependent on ions like sodium, potassium, and calcium. The conduction system is complex because it is measured as one of the most clever clinical tests there is, ECG or EKG. Even the things that don't extend out still get very complex. So we will radiate out from simple information and will build up through Bloom's taxonomy until we get to the real why questions of things like congestive heart failure or 12-lead EKG or diagnosing problems with the heart by looking at the EKG. I'll say this multiple times in the class, the urinary system is the most difficult system in AP2. That is because it incorporates everything from what a solute is to controlling ion levels to fluid volume, but the heart is definitely as complex and actually has a lot more content. This is the biggest and most complex Prezi that we have in AP2. This is a model I've drawn out to point out the need to build simple knowledge into complexity. Often in learning, the simple memorization of facts is thought to be learning. Learning was classified by Benjamin Bloom to have multiple levels. We remember facts. Understanding is the ability to explain facts. Applying involves executing the use of those facts. Analyzing involves breaking facts into parts and organizing them. Evaluating means to predict what happens when facts or conditions change. And creativity means to generate new ideas or constructions. In allied health, nursing, things like that, you begin by knowing the facts and eventually you will be analyzing a pathology to create a treatment plan. Even being good at taking facts and creating a plan is not enough in a course like AP2. You have to master skills as well. I will talk about this on the first day of class, but as a brief review, there's some big ideas in AP2, or I call them mastery skills. Can you critically think by asking questions, using digital literacy to begin to answer the question? Can you avoid faulty thinking? Can you share your brain and take advantage of someone else's brain? Can you see the big picture and then ask a better question? Also, can you simplify things that are complex? Simplifying things is a sign that you understand, and it will probably be a necessary skill to explain things to patients. Also, anatomy and physiology are how things look and how things work. You'll also need to extend that into clinical testing, which we've already mentioned with ECG. Can you see relationships to clinical care, watching sodium in the diet as it affects the heart? Can you see how drugs work? And this will be an exam question on the first test. And can you see how anatomy and physiology fail, leading to cause pathology? Applying Bloom's thinking helps you to gain mastery skills, and in turn, gaining mastery skills will improve your ability to think on many of Bloom's levels. So the two are like an hourglass that you need to keep turning over and over to build your skills. I will say this many times, college is not about facts, it's about skills. While AP1 was a lot more dependent on memorizing a lot of facts like bones, muscles, and cranial nerves, AP2 requires a lot more skill, thinking, and mastery. Before we get into the major areas, a few intro slides. The first slide is a bit of a dust slide. The major function of the cardiovascular system is to circulate things. You pick up oxygen in the lungs, and the cardiovascular system delivers it to all the cells. Do you remember what organelle it's using? You pick up nutrients in the digestive system, and you deliver those nutrients to every cell in the body. You pick up waste from the cells, things like urea and CO2, carbon dioxide, and you deliver those to the kidneys for removal. The overall study of the heart and diseases associated with it is called cardiology. The organelle that mainly uses oxygen is the mitochondria. What I'm trying to do with this question is I always want to pepper you with questions in AP2 in order to improve your test taking skills, your multiple choice test taking skills. because someday you're going to take a boards exam, which is going to be a very difficult multiple choice test. So I want to help you improve your multiple choice test taking skills. In fact, I would recommend that you get yourself an NCLEX book now if you don't already have one, or whatever boards exam you take, just to see how difficult those test questions are going to be. I'd bet that you'll be blown away. That should motivate you to work harder on your multiple choice skills in AP2. If you want to find a cheaper route, look up NCLEX on Quizlet. The reason I like this question is because it points out something that's pretty common in the media, and that is basically, in lay people, most people don't know the difference between heart attack, cardiac arrest, and heart failure. When Michael Jackson died, it was first reported that he died of a heart attack. And I remember thinking, this guy's so thin, there's no way he died of poor diet or fat in his arteries and a heart attack. What he died of is cardiac arrest. Michael Jackson took propofol that slowed down his breathing. When you slow down your breathing, you don't exchange CO2 as well, so you build up CO2. When you build up CO2, this causes acid to build up. It's called acidosis. Acidosis alters potassium balance. Most of the time you want potassium on the inside of the cells, but if hydrogen enters cells because it's gone up, you've raised the amount of acid, which means you raise the amount of acid outside the cell, and it enters the cell. When it enters the cells, then potassium will leave cells. So now we have decreased potassium inside the cells and higher potassium outside the cells. What that does to electrical cells is it makes them depolarize faster, and it makes it harder for them to repolarize. So in Michael Jackson's case, his heart would have contracted, and contracted really too long. The problem there is cardiac arrest. Arrest means the heart is not contracting anymore. It can be not contracting if it's held in contraction or if it's unwilling to contract. The other thing I'm trying to point out is when it comes to the heart, it has to do three main things. It has to pump blood to itself, and if it can't do that, tissue dies, and that's a heart attack. So blood is heart attack. The heart has to use electricity to contract in just the right sequence. Any interruption in the electricity is called cardiac arrest. The heart has to have enough muscle to pump the blood, and when that muscle is weak, it fails to move the blood. That is heart failure. So there's a difference between heart attack, which is a problem with blood flow, cardiac arrest, which is a problem with electricity, and heart failure, which is a problem with muscle. A big theme in this class is to see the big picture. I'll show you an infographic here soon, but Prezi is also that big picture. If we draw out really fast, you can see that the big picture is you have to know certain amounts of anatomy, then that's going to build into physiology, and it's going to build into mastery thinking. So there is a big picture here. Ultimately, what ties the big picture together is pathology. 29% of us, I said 30% before because I rounded, but 29% of us are going to die of heart disease in some form. So you need to look at things from the right perspective. I like these optical illusions as a metaphor for looking from the right angle. Here, we're looking at the wrong angle of that picture, and we're not looking from the right perspective, so things look weird. The right perspective, in my point of view, is pathology. Continuing that thought, if you're going into nursing especially, it's going to be incredibly time consuming. So anything you can do in AP2 to make your life easier when you get into nursing would be a gift to your future self. Often as an instructor, I think that what I'm trying to do is defend your future self from your current self that wants to be really efficient. You can do that too by working for your future self. Work hard at AP2. One of the ways you can do that is to start looking up these pathologies, even more so than we look them up in AP2. You might use PubMed, you might use Wikipedia, or you can go to professional organizations like the American Heart Association. If you look at things from the right angle, so here in that little optical painting or optical illusion painting, you're looking right down the painting and it looks kind of cool. So you saw before that the painting looked kind of weird, the lines look kind of weird, but if you stand in the right spot, all those paintings kind of line up and it makes this cool optical illusion. The right angle in AP again is mainly pathology, but also keep those big ideas in mind too of simplifying things and improving your critical thinking skills. I like to make tabloid relational diagrams to start to see the big picture. The main areas are listed. So basic anatomy, layers, valves, vessels, conduction system, congestive heart failure, cardiac output, and then something called the Wigger's diagram. The main areas are listed, but also pay attention to the orange stars. These are the pathologies associated with the major malfunctions in the heart. So things like endocarditis and myopathies or heart valve disorders, heart attack, cardiac arrest, homeostatic control, drug effects, heart failure, things like that. So keep linking pathology to the anatomy and physiology. Next, we go into size, weight, and location of the heart. So on the infographic, we'll start with the upper left corner with basic anatomy. Probably the simple anatomical things are size, weight, and location. The heart is about the size of your fist, maybe a little bit less, and weighs about 300 grams. Obviously, we don't really weigh hearts, but we're using that generally to refer to the thickness of the heart walls. A heavier heart will have thicker heart walls, while a lighter heart will have thinner heart walls. The heart lies, so position, the heart lies just superior to the diaphragm. So diaphragm is right here. The larger left side of the heart puts the heart to the left of the midline slightly. The heart is just anterior, just in front of the vertebral column, and just behind the sternum right here. Being stuck between these hard bones of the sternum and the vertebral column is why when you press on the chest, you actually get some compression on the heart, and you can push blood out of it to perform CPR. Continuing on with that application, the location of the heart is important to understand when performing CPR. The heart is about 2 fingers up from the xiphoid process. Xiphoid process is right there. Or here's the xiphoid process right here. Remember, that's the bottom part of the sternum. Placing your hands here is the proper place to administer chest compressions. And again, you're pushing on a bony structure, the sternum, and you're pushing the heart into a bony structure, the vertebral column. That's heart location. Just by looking at these, do you have a sense of which one is normal? I guess we're talking about weight. Can you guess the one that is too light and the one that is too heavy? I guess that's pretty obvious that you choose this one as too heavy because that's the heaviest one. This one's too light because it's the lightest one, and A is the normal. Clearly C is bigger than the fist and weighs more than 300 grams. This is called hypertrophy. Just as your biceps will grow larger if they're consistently stressed, the heart will grow larger when stressed. The stress for your heart is usually high blood pressure, though it could be things like hardened valves or difficulty pushing blood through the lungs in asthma or any kind of respiratory pathology. I like A here. Which of the following would you guess are not true? I like A. When heart muscle, like any muscle, expands when it has to work harder, that's true. High blood pressure makes it hard for the heart to pump, that's true. I don't like this one because your heart does not function in a whatever doesn't hurt us makes us stronger kind of way. Whatever hurts us, hurts us. A problem with the heart is that the blood vessels are on the outside of the heart. So as the heart muscle thickens, it gets harder to get blood to the inside of the heart. So you're not going to get blood to that inside of the heart, and that means that tissue is going to die. So if the inside of the heart doesn't get enough blood, it'll start to die. So eventually the heart will get bigger and bigger, but the walls will become thinner as the inside of the heart dies out. This is called a dilated heart. Unfortunately, this will solve the high blood pressure problem, but now the heart will not be able to pump blood very well. Do you remember what it was called when the heart is too weak to pump blood? If you don't remember, you might want to start the video over again. Do keep going back if when I ask you these questions you don't know the answer. So don't just make it through the video and speed up through the video and think, well, I've watched the video and therefore I'm done. Watching the video doesn't do anything for you if you're not actually learning, and you know you're not learning if you can't answer the questions. That's a thing called formative assessment, where it basically helps you to formulate learning by checking to make sure that you're actually learning. So if you're missing these questions, go back. Recall that the heart has 3 major problems. What was it called when there was a problem with muscle? Here's your hint. Here's your hint over here. Next up is chambers of the heart. So continuing on with basic anatomy, we'll now turn to some gross anatomy. That's anatomy that you can see with the naked eye that includes the chambers of the heart. As it says, for the most part, you'll need to be able to label all figures like the one below. Honestly, just doing the labeling would have been your task in AP1. There won't be any simple labeling like this in AP2. You'll need to be able to do the labeling to answer the question that comes from higher in Bloom's taxonomy. So something like, what blood vessel would need to be bypassed if an EKG noted abnormal electrical activity in the inferior right portion of the heart? And you would say, that's the marginal artery. So you're not going to be asked to label the marginal artery. You're going to be asked an application of the marginal artery. The heart consists of 4 chambers, 2 atria, and 2 ventricles. The atria are superior, and the ventricles are inferior. They are, isn't it nice when anatomists use simple terms, named right and left. Let's also talk about the major blood vessels. We'll be a bit redundant with these. The inferior vena cava and superior vena cava return blood to the heart. The aorta, in red, and the pulmonary trunk deliver blood out of the heart. Let's start to be a little bit more specific. The vessels conveying blood away from the heart receive blood from the ventricles. So the ventricles pump blood out of the heart. The pulmonary trunk receives blood from the right ventricle and delivers blood to the pulmonary arteries and then to the lungs. The ascending aorta, shown here in orange, receives blood from the left ventricle and delivers it to the systemic circulation to nourish the body. The first 3 branches off the aorta, I always remember them as the BCS, as in the Bowl Championship Series in college football. So the first 3 branches are the brachiocephalic, the B, left common carotid, so C, and the subclavian arteries. So brachiocephalic, left common carotid, and the subclavians. Vessels returning to the heart deliver blood to the atria. The superior vena cava, outlined in orange, returns blood from above the heart. The inferior vena cava, here in yellow and kind of tucked in behind, returns blood from the lower extremities, regions below the heart. The pulmonary veins, kind of hidden here, but right here, there's 4 of them, return blood from the lungs to the left atrium. Here's a posterior view of the heart. Note the left and right pulmonary veins, so there's 4 of them again. The superior vena cava, the inferior vena cava, and the right atrium is right here. In this frontal section, find the major vessels and chambers again. I'm not a huge fan of lecturing anatomy because it's just me pointing things out while you passively listen and possibly fall asleep. I think it's best if you're more active in the hunt and identify things on your own. Again, you'll hear most of these terms as we proceed on, and you'll want to know them. So you might want to stop the video and learn these terms, or at least start getting to know these terms. Can probably skip moderator band, but the rest of them you'll want to know. When it comes to AP2 and in anatomy in general, redundancy is a good idea. We'll circle back often. We'll repeat some things and add a bit more detail so things stay connected, but we're also building. The atria receive blood. There are pectinate muscles, little bumps of muscles that assist with contraction. Blood enters the right atria from the superior vena cava, the inferior vena cava, and a structure we'll talk about later called the coronary sinus. That's how blood gets back to the right atrium from the heart itself. Blood enters the left atrium from the pulmonary veins, the 4 pulmonary veins. So again, here, they look like they're going into the right atrium, but they're passing behind the heart and going into the left atrium. The ventricles are the discharging chambers. Trabecular carneal muscles line the walls of the heart and are thought to prevent the walls of the ventricles from sticking together after contraction. A bad thing is that blood clots can form on this spiderweb-like structure, especially if the heart stops. Papillary muscles, down here, support the valves to prevent them from turning inside out. So the valve, we don't want it to flip back up into the atria, and those are held by the papillary muscles and something called chordae tendineae. The right ventricle pumps blood into the pulmonary trunk. The left ventricle pumps blood into the aorta. There are 2 circulations. The pulmonary circuit pumps blood to the lungs and back. The systemic circuit pumps blood to the rest of the body. Repeating that, there are 2 circulations. The pulmonary circuit pumps blood to the lungs and back. The systemic circuit pumps blood to the rest of the body. And I don't say to the rest of the body and back because once blood makes it to the end of the line in the systemic circuit, it doesn't really feel the push of the heart anymore, and there's other ways for the blood to get back to the heart once it's gone through the capillaries or the smallest vessels. We'll talk about that when we get to the blood vessels. Here, I give you some possible options. So the reason there are 2 circulations is Oxygen loading is improved by slowing the circulation through the pulmonary circuit. Pressures are lower in the pulmonary circuit. The circulation is too large to be served by only one pathway, or all of the above are correct. Pause for a second and try to think through the options first. Again, you want to get better at multiple choice, and just listening to me explain doesn't help as much as if you first make your guess and then listen to the explanation. That's the way to improve your multiple choice test taking skills. The circulation has to go at one speed, as it's one long continuous loop. There are times when blood may pool in some places, but the heart will make adjustments to make sure it is pumping the same amount of blood using something called preload. So the systemic circuit and the pulmonary circuit essentially have to pump the same amount of blood because they're in one large continuous loop. We'll come back to this thing called preload, but at this point I just wanted to get that word into your head so you know that you've heard it twice when we bring it back again. C is wrong because there's animals with much larger circuits than the whole human circuit, so length isn't really the limitation. The difference between the two circulations is that the pulmonary circuit has a much lower pressure to preserve the delicate structure of the lung. The lung's delicate because you want as small of a barrier as possible between the air and the lung. So we have air in here. The little red guys are capillaries. The little red guys here too are capillaries. We want as little of a barrier as possible between the air in here and the capillary. That means this structure is pretty delicate, which means the blood pressure going through here has to be pretty low. So the reason you have two different circulations is you need two different pressures. You need high pressure in the systemic circuit to get blood all the way out to your big toes. You need low blood pressure in the lungs so that you can have a very thin capillary to allow oxygen to get into the capillary easily. Blood pressure in the lungs is about 20/8, as opposed to it being 120/80 in the rest of the body. There are three main types of vessels. There are subtypes too, but we'll wait until we talk about blood vessels specifically to talk about those other types. So things like arterioles and venules and things like that. Arteries carry blood away from the heart, and veins carry blood to the heart. Capillaries allow exchange of gases and nutrients within the tissue. It's a common misconception that arteries are defined as carrying oxygenated blood and veins carry deoxygenated blood. Again, these vessels are defined by the direction of blood flow, not by whether they carry oxygenated blood or deoxygenated blood. It's most often the case that arteries carry oxygenated blood, but there is an exception. It's a classic trick question in A&P tests and probably also in boards tests. Seen it in NCLEX questions for the boards as well. So do you know the exception? The exception is blood leaving the right side of the heart is going out to the lungs. So these are arteries. These are the pulmonary arteries in blue. But since this blood has been to the entire body and back, it's technically deoxygenated. When we get to that section in the respiratory system, you'll realize that it's really not that deoxygenated. It's still carrying 90% oxygen. But compared to the 98% of oxygen in arteries, blood in the veins is deoxygenated, even though it's only 90% oxygen. And just to continue that thought, then the pulmonary veins are returning to the heart, but they're returning to the heart from the lungs where they just picked up a bunch of oxygen. So the pulmonary veins are actually oxygenated or carrying oxygenated blood. So to find the exception again, find the artery on this figure that's blue and find the vein that is red. At this point, you should start to get your anatomy down by following the path of a red blood cell from right atrium back to right atrium. You should be able to do it now with the terms in white. The ones in green we're going to get to shortly. Soon we'll even add more, so we'll add types of vessels. And when you can learn your anatomy as a story, pretend that you're a red blood cell and follow the sequence of anatomical structures you would go through from right atrium to right atrium. Honestly, it's not something you have to do in lecture, but it is going to be a question on your practical in lab. This is a great question. I'm not really going to go into it in too much detail because we'll do it in learning catalytics. When you really know your circulation, you'll see the problem with transposition of the great vessels. Also, I'd never wish this upon anyone, but while many of you are learning this because you want to go into healthcare, you never know when learning this might help you better weather a situation in your life. I had a student several years ago in AP2 who has gotten married in the last couple of years and had a child and ended up having a child born with transposition of the great vessels. That was Brianne T. Next is heart valves. You wouldn't think that this little flap, so here's an example, or the little valves are here. You wouldn't think that this little flap would be all that important, but mitral valves will be our first opportunity to study the cluster mess that can occur in anatomy, physiology, and pathology. That little flap can cause blood pressure to get too high in the lungs and too low in the systemic circuit. Begin to think about what the consequences of those conditions would be. Again, too high of pressure in the lungs, so the pulmonary circuit's blood pressure goes up, and too low of pressure in the systemic circuit. Systemic blood pressure goes down. In this class, it's often more important that you can think through things logically rather than looking things up to memorize the clinically exact answer. We will research things too, but also just try to think and be logical. Valves make sure that the blood does not flow back in the wrong direction, so the AV valves, here in orange, will prevent blood from going back into the atria when the heart contracts. So when the heart contracts, we want blood to go out the great vessels, which is the pulmonary trunk and the aorta, so go back out this way rather than go back up into the atria. So the AV valves prevent blood from going back up into the atria. The valve on the right is the tricuspid, and the valve on the left is the bicuspid. I remember this often by saying, try to get the answer right. Try is on the right. Or some people say, try before you buy, as in you try out a car before you buy a car. So the try comes before the buy. Sometimes in anatomy, a structure will have two names and each are used, so you need to know them both. Even for more detail, often one name is more old, so like the mitral is the older term for the bicuspid. Usually if you're talking about the anatomy of the heart, you use the term bicuspid. But since a lot of diseases have been known for a long time, it still uses the old word, so you have mitral valve stenosis or mitral regurgitation. So it can really be called both terms. There are also valves that prevent blood from re-entering the heart after it's been pumped into the pulmonary trunk and the aorta. When the heart contracts, it pushes blood out strongly, but when the heart begins to relax, blood tries to flow back through these great vessels. The semilunar valves, the pulmonary semilunar in the pulmonary trunk and the aortic semilunar in the aorta, prevent this backflow. Often the name semilunar is dropped, leaving the aortic valve and the pulmonary valve. Here's a top-down view of the four valves. Which valve of the heart do you think is under the most pressure? Later in our material, we'll use something called the Wiggers diagram to actually show you the answer, but at this point, just try and make a logical guess. Which valve do you think is under the greatest pressure? We'll save that till we get to the Wiggers diagram. What outcomes of fen-phen could be expected? You'd need to do a little bit of research here on what fen-phen is, unless you're old like me. We'll have a case study on fen-phen in the lab. We'll point out how much damage can arise from damage to the valve. So what fen-phen did is it damages the mitral valve, or really any valve, but the mitral valve is under quite a bit of pressure, or the aortic valve is also under a lot of pressure. The drug ultimately was taken off the market and resulted in $13 billion in legal damages. I remember when these damages were awarded, and it seemed like a lot of money until I knew a little bit more about anatomy and physiology. So if you investigate more into the damage that can arise from damage to a heart valve, the $13 billion won't seem so unbelievably high. The drug definitely shortened a lot of lives. The story gets even more interesting when you realize the drug targeted serotonin receptors. If you recall serotonin receptors from AP1, they're generally associated with mood and sleep. An odd thing is serotonin also is used by platelets to signal that they've found a cut in a vessel. So what a complex body we have when serotonin does all these many different things. Helps us sleep, has platelets talk to each other, and does something in heart valves. Now that we added the valves, our list gets up to 13. As I've said, simply asking you to label these out as a little below us in AP2. I'll admit that this is a question on the practical, I said that before, but on the exam, this sort of question is usually a simple multiple choice where you need to pick out the sequence that is incorrect or correct. So if I said a red blood cell goes from the right atrium to the bicuspid to the right ventricle, you need to know that that's incorrect because it should have been the tricuspid. So being able to list out the steps will make sure you get that correct on the exam. So listing it out is definitely a requirement of the practical, and it may help with multiple choice on the lecture test. Put these valves in correct order. And heart sounds. Just as when doors close, they often make a noise, when the valves close, they make a noise as well. There are other sounds, but the first and second heart sounds can be assessed to diagnose many possible pathologies like leaky valves, stenosis or hardened valves, and valves that regurgitate, which means they let blood go back in the wrong direction. The valves of the heart make two primary sounds. The first is often characterized as a lub, and the second as a dup or a dub. And you'll see that I mix them up or I interchange them. Some people call it a dub, some people call it a dup. Either works. When you try to match up the heart sound with what's going on in the heart, you might naturally jump to the lub is atrial contraction, and the dub or dup is ventricular contraction, because you know you have these two major events in the heart, atrial contraction, ventricular contraction. But the actual alignment is the lub equals ventricular contraction, and the dup or dub equals ventricular relaxation. Now think it through a little bit. When the ventricle contracts, blood tries to go back up into the atria, so the AV valves close. That's the lub. As the heart then relaxes, blood tries to flow back from the aorta and pulmonary trunk into the heart, and the aortic and pulmonary valves close. That's the dup. Maybe try to do some Googling to find some sites. Probably should have listed that as SITES to help you work on heart sounds. The thing about A&P and healthcare in general is you need to learn how to improve using your senses. You probably haven't had to use all your senses in other classes, but you will have to use all your senses in A&P and certainly in healthcare, where you see color and cyanosis when somebody's lips turn blue or somebody looks pale. Or they might turn jaundiced. You need to see the yellow in the skin. You need to smell things like necrosis, or maybe even if someone's in ketoacidosis, you'll smell acetone on their breath. Or if someone's breaking down too much protein, they might smell like ammonia. So you need to be able to touch and feel, see, and smell in A&P and in healthcare. I said most of this in the last slide, but now think it through again with this picture. When the ventricle contracts, blood tries to go back up into the atria, so the AV valves create a lub sound. As the heart relaxes, blood tries to come back through the pulmonary trunk, back through the aorta, and so the semilunars close. When the semilunars close, they cause the dub or the dup. Again, you get the lub when the ventricle contracts, and the dub when the ventricle relaxes. You can hear some additional sounds of blood moving, but we'll stop at lub and dub for now. Here's a portion of the Wiggers diagram that shows how heart sounds. So the first heart sound is lub, second is dub, how they line up with valves closing. So you can see that the valve closings are labeled here. If you want to be particularly challenging, think about why the valves close right then. So clearly the AV valves close when the pressure is greater in the ventricles than it is in the atria. And then they open when the pressure in the atria gets bigger than the pressure in the ventricles. Similarly, the semilunar valves open when the pressure in the heart is greater than the pressure in the aorta, and they close again when the pressure in the aorta is higher than in the ventricles. When listening to the heart, it's best to get some separation to hear the individual valves, and also to get out from over the sternum. So we want to not be over top of the sternum, which will mute the sound. By listening to the various valves, you can also detect slight differences in their opening. So for example, the mitral valve often closes just before the tricuspid. A change in the sequence can indicate a problem with the electrical flow in the heart. Normally, the aorta closes just before the pulmonary, especially during inhalation, as the decrease in pressure that allows air to flow and move into the lung also decreases pressure in the pulmonary trunk, so the pulmonary valve does not close as quickly. So if there's less pressure in the pulmonary valve because there's less pressure in the air around the pulmonary trunk, it's not going to close as quickly. So a wide split in the dub can indicate a lot of problems. Remember that one of our big ideas in the class is how beautiful humans are when it comes to clinical testing. We can perhaps find a developing problem with the electrical system of the heart with a simple stethoscope. Humans are also really dumb when it comes to clinical testing, because maybe we should be able to make these basic diagnoses to monitor our own health. And unfortunately, I say that as someone myself who knows how to describe that, but I haven't trained my ears how to hear it. Second heart sound described as the dup is actually the sound of. It would actually be the semilunar valves closing, so D, as blood tries to re-enter the heart through the pulmonary trunk in the aorta. That's the dup. So again, we'll do this in lab, but you might want to look up things like fen-phen, and we'll do a case study on this, because what fen-phen does is it harms the mitral valve, and when the mitral valve gets stuck, blood pools in the left atrium, which drives up pressure in the lungs, and also, since blood can't get into the left ventricle, it lowers the pressure in the ventricle. So it causes pulmonary high blood pressure and systemic low blood pressure. And then just think through, what could that possibly mean? What if you have high blood pressure in your lungs and low blood pressure in the rest of the body? Again, be logical. Don't necessarily look for a web page to tell you the exact answer. Just be logical. Next is layers of the heart. When there's inflammation of the layers, we get pericarditis. Also, since one of the layers of the heart is the muscle, the thickening and thinning of the muscle we talked about earlier when discussing the size of the heart, size and weight of the heart, can also be considered issues with the layers of the heart. So hypertrophies are problems with the layers of the heart. Multiple layers around the heart. The first division is the outer pericardium, which itself is composed of several layers, and the inner myocardium here in yellow. So pericardium in orange, myocardium in yellow, both contain multiple layers. The layers of the heart protect and anchor the heart, so they prevent it from overfilling, and it also protects the heart from friction. The heart has to be fairly free to move, so the limited anchoring of the heart is provided by the layers. Do you remember how actin and myosin overlap and slide past each other in skeletal muscle? When you strain a muscle, you can pull the actin and myosin filaments so far apart that they don't overlap. If this is your skeletal muscle, you just wait for the muscle to heal and the filaments overlap again. You don't have time to heal. You can't just rush your cardiac muscle, so the sac around the heart limits the stretch of the heart muscle so the actin and myosin filaments don't pull apart. If you wish, try to find videos of the heart beating in vivo in life, and you'll see that it's a very active, almost violent process. They actually, before they're going to transplant hearts now, even when they're transporting a heart to be transplanted, they'll often keep it beating. So there's videos out there of a heart beating, in life, or in situ, which means like in glass, which means it's been pulled from a body, but it still has life. So the layers also protect the heart from abrasion while it's going through this violent beating process. Let's start going through the layers of the pericardium. This is a common pattern in the body where when we're talking about layers, whether it's blood vessels, the small intestine, the heart, the outermost layer is for strength. So remember that when we're talking about blood vessels, heart, or also the digestive system. The outermost layer, in the case of the heart, is the fibrous pericardium, and it's really strong. The next layer in the heart is called the parietal serous pericardium. So parietal means up against the wall. So the parietal serous is up against the wall created by the fibrous pericardium. The parietal serous pericardium folds into a double layer. So here it would be green, and it folds back into this yellow layer. And this yellow layer is the innermost layer also, and it's called the visceral serous pericardium. So visceral means inside, as in your visceral organs are inside of you. The space between the serous pericardiums is called the pericardial cavity, and it contains fluid. Next, we'll move into the myocardium, which is also called the heart wall. The heart wall has 3 layers. The outermost one, or the epicardium, is actually the visceral serous pericardium. So same layer, but with 2 different names, based on whether we're talking about the pericardium or the myocardium. The next layer in, the big layer, is the myocardium, which is composed of cardiac muscle itself. The innermost layer is called the endocardium. This is a thin, smooth layer of cells that allow blood to flow easily through the heart. If you had to guess, do you remember your histology at all? If you want a thin layer that's really smooth, what type of cell do you use? You also use this type of cell in the lungs because it's thin and it creates a thin barrier between the air in the lungs and the blood vessels. Simple squamous. Simple squamous make the air sacs of the lungs, also line blood vessels, and line the inside of the heart. Here's just a nice shot of the heart wall. So the big thick left ventricle right here. So notice how much thicker the left ventricle is versus the right ventricle. It's also interesting to see the trabecular muscles make a web that keeps the inside of the heart from sticking together. So unfortunately, if the heart stops, here we can see it even better, that there are places where blood will get in there and form tiny clots. So after cardiac arrest, clots might be released when the heart is restarted, unless they have what are called reperfusion strategies. So you need to make sure you break up those clots before you get the blood to start moving again. Otherwise, those clots will move into the lungs or into the brain and cause an embolism, a pulmonary embolism or cerebral embolism. If a knife penetrated the heart, which is the correct sequence? Well, we know it's not going to be epicardium. It's not A because epicardium is not the inner one. I don't like B because it doesn't go myo, para. I don't like C because endocardium is the most inner layer. I like E. I'm liking E because it's epa, myo, endo. Next up is coronary circulation. Major pathologies associated with coronary circulation would be coronary artery disease and heart attack. The treatments might include stents to open up vessels or coronary artery bypass graft or CABG, which is routinely called a bypass surgery. Coronary circulation is the functional blood supply to the heart muscle itself. Look how significant it is. As you can see from the figure, the blood vessels are on the outside of the heart. There's several collateral routes, and the blood vessels split down into very, very fine capillaries. There are 8 main vessels on the front of the heart. A major artery off the right coronary artery. So first, I guess we should do the right coronary artery comes off the aorta, and that's right here. One of the first divisions is the right marginal artery. An easy way to remember this artery is that, like the margin of a piece of paper is on the side, the marginal artery is off to the side of the heart. While the right coronary artery is long and it's going to continue around to the back of the heart, the left coronary artery is shown passing behind the pulmonary trunk right here. It travels about an inch before it splits. It splits into the anterior interventricular artery. That's a nice name because it's interventricular, which means between the ventricles. And then it's on the front, so it's the anterior interventricular artery. It also splits into the circumflex artery, which will go around the back of the heart. Circum means around, as in when you circumnavigate the globe, you go around the globe. So the circumflex artery goes around the heart. Okay, so right coronary artery splits into the right marginal artery. Left coronary artery comes off the aorta. It's very short, splits into anterior interventricular, splits into the circumflex, which will go around to the back of the heart. The great cardiac vein is on the front. I got my little animations mixed up here. They should be slid over a little bit. Great cardiac vein starts at the apex and moves up the anterior interventricular groove. Small cardiac vein runs along the marginal artery. Then we also have the anterior cardiac vein. Moving around to the back of the heart, there's 2 major arteries and 4 veins. So the right coronary artery over here is continuing around from the front and continues down the back of the heart as the posterior interventricular artery. So again, between the ventricles, so it's interventricular, it's on the back now. This one's on the back. So this one's called the posterior interventricular artery, much like you had one on the front called the anterior interventricular artery. We'll next find these 4 veins. The great cardiac vein moves to the back of the heart, so it came up the front and now it moves around to the back of the heart, and we can see it right here. Posterior vein of the left ventricle and the middle cardiac vein brings blood up the back of the heart. Lastly, on the back of the heart is the atrioventricular groove, so between the atrium and the ventricles, there's a large sinus there that collects blood when the heart is contracting and then delivers that blood to the right atrium during relaxation. This is called the coronary sinus. So this larger vessel right here is called a sinus. It's called the coronary sinus. Which of the following factors gives a mitochondrium its high resistance to fatigue? You might want to guess around that one a little bit first, or guess about that one. What causes muscles to get fatigued is not enough blood flow and not enough oxygen. Well, technically not enough oxygen, and you don't have enough oxygen because lack of blood flow. The coronary circulation makes sure that the heart always has plenty of blood flow, and so the coronary circulation makes sure that the heart never gets fatigued. And that's shown here too. I guess I skipped ahead a little bit. So remember from AP1 that you get ATP from creatine. That's about 15 seconds worth of energy. Then you can also get ATP from glucose in the presence of oxygen down here, where you get 36 ATP, or when oxygen is lacking, so that's called anaerobic respiration, and you build up lactic acid. That causes fatigue and burning in the muscle. Well, as long as you have plenty of oxygen, you get to make lots of ATP. How do you make sure you have plenty of oxygen? Make sure you have plenty of blood flow. So the major factor in muscle fatigue is insufficient blood flow. The heart doesn't fatigue because of the immense blood flow. It also has a protein called myoglobin, which is much like hemoglobin that holds oxygen in your blood. Myoglobin holds onto oxygen for the heart to make sure there's always oxygen available, and it can always make plenty of ATP, not go into fatigue, not go into a burn state caused by lactic acid. Which of the following vessels is most likely to supply the anterior left ventral myocardium? Wouldn't be the marginal because that's on the right. It's probably not the circumflex because that goes around to the back. Right coronary artery is towards the right. I like anterior interventricular artery. That does supply the anterior left ventricular myocardium. And that's often one that's bypassed in CABG surgery. Patient reports pain in the lower right portion of the heart. You really couldn't sense pain like that, but you could visualize that there's a blockage. So if you visualize that there's a blockage in the lower right portion of the heart, the best answer there would be the marginal artery, or C. Okay, now is when things start to get a little bit more difficult because we're going to start going into heart muscle cells, conduction cycle, EKG, action potentials, and things like that. So next we turn to cardiac muscle. Cardiac muscle is striated, so it has these stripes going this direction. You can kind of see those. Cardiac muscle is short. They're fat cells. They're branched, so we can see that there's multiple cells that are branched, or maybe it's better to see it in this artist rendition. And they're also interconnected by things called intercalated discs. The striations are due to myosin and actin. Remember that from skeletal muscle. The branching is so that electricity can spread. So we start our signal to have our heart contract at one place called the SA node, and that signal has to spread. For the signal to spread, the muscle has to have branching. The cells are also interconnected because the electricity has to flow from cell to cell to cell. So intercalated discs anchor cells together and allow tunnels between cells for ions to flow. There are not any nerves coordinating the electrical activity between cells in the heart. Of course, there are nerves that are modulating the heart, slowing it down and speeding it up, but it's not nerves running through the heart that allow it to contract as a unit. It's that the ions flow from cell to cell to cell through the intercalated discs. Also, so these ions can flow from cell to cell to cell, often the nuclei are off to the side to get out of the way of that ionic flow. You'll see different people say different things about whether the nuclei are in the middle of the cell or off to the side. I tend to see it the way I want to see it, I suppose, which is they're off to the side because ions need to flow from cell to cell, and you don't want the nucleus right there in the middle disrupting that ionic flow. On this image, you can see the branching, the intercalated discs. You can kind of see the striations and the presence of desmosomes. Desmosomes are these little things here. They're right here in pinkish, I suppose, that hold the intercalated disc together, or that hold the cells together at the intercalated discs. It's sort of hard for me to believe, maybe it is for you too, but even while the heart can be influenced by nerves and also hormones to speed up and slow down, it doesn't really need nerves. You don't need nerves to keep the heart electrically coordinated. One of the things that does keep things electrically coordinated are something called refractory periods. And we'll talk about this later, but what it means is after a cell is excited, it goes into a sort of timeout so that it cannot be activated again by neighboring cells. This timeout keeps the pacemaker of the heart in control. So try to recall when you've heard of refractory periods, when we talked about action potentials in the brain, and then we'll explain this more when we get to cardiac action potentials. There are two types of cells in the heart. Autorhythmic cells are the nervous system of the heart. They're not nerves, but they're cardiac muscle cells specialized to carry the electrical system signal quickly and set the pace of the heart. Muscle cells are sort of the worker bees of the heart, contracting to pump blood under the direction of the autorhythmic cells. So autorhythmic cells are kind of like the electrical system. Muscle cells do the work. I'm going to draw all of this out on the board. We'll draw rectangles like down here, and then walk through the action potentials of both the AR cells and the cardiac muscle cells. In the figure of the heart, the AR cells are in yellow, see those here, and the rest of the cells are in pink. That's why we're coordinating these colors. As a reminder, action potentials are when a cell can change its voltage over time. Recall that all cells have a voltage created by the sodium-potassium ATPase, or sodium-potassium pump. Some cells, like neurons, muscles, AR cells, and CM cells, will change that voltage over time to conduct rapid signaling. So changing the voltage fast is a rapid signal. The reason we want to know about action potentials is that they are dependent on ions like sodium, potassium, and calcium. Do you hear how fast I say that? I've said sodium, potassium, calcium so many times in my life, and you're going to say it multiple times too, because we can alter sodium, potassium, and calcium in our bodies with diet, pharmaceuticals, fluid imbalances, and kidney problems. So when we alter these ions and alter electrical signaling, things can go pretty bad pretty fast. Do you remember what it was called when the electrical system of the heart is altered? So there was blood, electrical system, and muscle. While we're going to draw out cardiac muscle action potentials on the board, and there's a YouTube video of that as well, I'm going to lecture through the physiology here slightly in slide format just to give you another possible way to hear the story of action potentials. It's called cardiac arrest. Action potentials in the AR cells set the pace of the heart. So AR cells form the actual pacemakers. There's one main AR pacemaker, but backup ones exist as well. So if that one doesn't work, other pacemakers take over, and they're usually slower than the SA node. AR cells also form the electrical system called the conduction system of the heart that coordinates muscle contraction. The bottom panel here shows the specific ions that move to give the AR action potential. So we're seeing sodium, calcium, and potassium. The action potential here is similar to the one in neurons. Sodium is used to raise the voltage, called depolarization, and potassium is used to lower the voltage, called repolarization. Notice that, unlike in neurons, calcium also participates in the action potential in AR cells. So calcium didn't help with action potentials in neurons. It helped with neurotransmitter release, but it didn't form the actual action potential. Here, calcium plays a major role in depolarizing AR cells in the cardiac AR action potential. We'll talk through all the parts of this next, but take a quick look at the AR action potential. Some of you may recognize more of the details of what is going on, depending on how well you remember action potentials from AP1 when we talked about neurons and muscles. But I'm going to lecture this out as if you've never heard of action potentials before. The action potential in AR cells doesn't really do anything other than keep time. It's like a metronome. It just sets the pacing. It doesn't really contract muscle or anything other than set a beat now, beat now, beat now signal for the rest of the heart. Cardiac muscles. Before we move on to the specifics of action potentials, let's take a quick look to acquaint ourselves with the basics of cardiac muscle action potentials. So again, taking a bird's eye view, and then we'll come back with some detail. The first thing to note is that there is a change in the role of calcium. In AR cells, calcium played a role in depolarizing the cell. In cardiac muscle cells, sodium alone depolarizes the cell. Calcium enters after the cell has already been depolarized and actually causes contraction of the muscle, just as it did with skeletal muscle. Recall that calcium binds to troponin. Remember this from AP1. Calcium binds to troponin. Troponin moves tropomyosin out of the way so that actin and myosin can interact and cause sliding in the cross-bridge cycling. So cross-bridge cycling function. And that's what causes the filaments to slide along one another and contract. Here again, just take a quick look at the cardiac muscle action potential to get your brain started laying down what's going on. So sodium enters and causes depolarization. Technically, both calcium channels and potassium channels are open here at the same time. The calcium channels close, and the potassium channels bring the voltage back down and repolarize the cell, just as potassium repolarizes the AR cell and repolarizes neurons. Here's that infographic again. If you want to copy this, find the video on YouTube, and there's a link to the file under the More Info tab. That's a good thing to find on any YouTube video, because any YouTube where I make an infographic, a link to the infographic can be found under the More Info tab, and that's not always evident right when you open up YouTube. I'm showing this figure again because I cut it apart to lecture action potentials. So an action potential is a change in a cell's voltage. The cell's voltage is referred to as the voltage of the membrane, and it's abbreviated VM, and it's expressed in millivolts. So a typical cell voltage is listed as having a VM of -60, -70 millivolts. A voltage is sometimes called a potential. I'm guessing, but I guess the fact that the voltage is changing is why it's called an action potential. The voltage is changing, the voltage is a potential and has action, so it's called an action potential. The first thing to ask is, how did we get the voltage in the first place? The voltage is established by a sodium-potassium pump in the cell's membrane that pumps 3 sodium ions out of the cell and 2 potassium ions into the cell while using an ATP molecule. Since you're pumping more sodium out and potassium in, this sets up an ion gradient where the sodium is on the outside, most of the sodium is on the outside, and most of the potassium is on the inside. And then these ions are going to want to move down their concentration gradient. Sodium is going to want to come in, and potassium is going to want to leave. Also, a charge gradient is set up. Some of the charge gradient is because 3 positively charged sodium ions are pumped out of the cell, but only 2 positive potassium ions are returned to the inside of the cell. So we're pumping out 1 positive charge per pump cycle. Pumping out 3 positives, only taking back 2. That equals pumping out 1 positive charge per cycle. Turns out that this is only partially responsible for the voltage of the membrane. Most of the VM is set up by letting more potassium leak back out of the cell, and when that positive ion leaves the cell, it makes the inside of the cell more negative, versus the amount of sodium allowed to leak back in. Since potassium leaks out following its concentration gradient, this adds more positive charges to the outside of the cell. With voltage, we don't talk about the positive charges outside the cell. We talk about the inside of the cell having more negative charges. So by pumping out more positives and by letting potassium leak out more than sodium comes back in, the inside of the cell takes on a negative resting voltage. Once we have the VM set up, we need to change it to get an action potential. Because we have a concentration gradient, sodium will move into the cell, and potassium will move out if allowed. We can make the voltage more positive if we let sodium back into the cell, because it's going to follow its concentration gradient, move into the cell, make the inside of the cell more positive. Or, because of the concentration gradient, if we let potassium out, potassium will leave the cell, take a positive charge with it, and that'll make the inside of the cell more negative. So you can start to see the action, and the action potential is to change the voltage to positive by letting sodium in, or to negative by letting potassium out. The next question is, how do we control when sodium is allowed back in to make VM more positive, or when potassium is allowed out to make VM more negative? The answer is voltage-gated ion channels. Voltage-gated ion channels have gates with positive charges that respond to the voltage inside the cell. When VM gets less negative, so goes from -70 to -55, then the positive charges are no longer as attracted to the inside of the cell, so the gate slides out and the gate is open, or the channel is open. So when VM gets less negative, the positive charge on the gate is not as attracted to the negative charge inside the cell, and the gate moves out and opens the channel. Voltage-gated channels then have some sort of timer mechanism that has them close after they're open for a certain amount of time. As it says here, different voltage-gated ion channels exist to let through different ions at different voltages. We'll step through the individual channels and then step through them to explain the overall action potential. By and large, we have sodium channels, calcium channels, and potassium channels. Sodium channels usually open at -55 millivolts, which we can see here at -55-ish, or here it's open at -60 millivolts. Sodium follows its concentration gradient and enters. Since sodium is positive, it makes VM move towards positive voltages. I don't expect you to memorize exactly what voltages channels open at because it differs by cell, but generally sodium channels are the first channels to open to depolarize cells, whether it's a neuron, cardiac muscle cells, or autorhythmic cells in the heart. Calcium channels. There are two types of calcium channels that allow calcium to enter and depolarize cells. The first thing that we should note is calcium is mainly concentrated on the outside of the cell, and it wants to enter inside the cell. Also, calcium is a positive ion, so when it enters the cell, it depolarizes the cell. There's fast calcium channels that open at around negative 40 millivolts and stay open for a short time. So they open here in red at negative 40 millivolts, and they open for a very short period of time. There's also slow channels that open at around 0 millivolts, so they're opening around here, or plus 30 millivolts too, probably closer to plus 30. Opens at plus 30 millivolts and maintains the plateau of the cardiac muscle action potential. So it opens here and doesn't close for about 180 milliseconds, which is a long amount of time when it comes to ion channels. That's why it's called a slow calcium channel. It's slow to close. Potassium channels usually open at around 0 or sometimes plus 30 millivolts, depending on the type of cell. Potassium follows its concentration gradient and leaves the cell. So since a positive ion is leaving the cell, this moves Vm towards the negative. Technically, there's multiple types of potassium channels, but that's not really extremely important to us, and so we're going to group them all together. So there's like 5 different potassium channels in cardiac muscle cells. Getting even more specific, so let's go through the very specific actions of action potentials in AR cells first and then in cardiac muscles. So I realize I'm being very repetitive and I'm trying to break things down into simple steps and build them up a little bit at a time. It's better to be a little bored than completely confused. So make sure that each small step makes sense so everything comes together to create an understanding of action potentials. Everyone should know a little bit about action potentials because it's the electricity that neurons, muscles, and the heart use. Even if you're not necessarily going to nursing, you'll want to know this kind of things because we can alter these action potentials with our diet, with drugs, and fluid imbalances that may arise from multiple different causes, or kidney failure is one of the major ones. As an example, when you have low calcium, muscles get overexcited and cramp. If you think through that, you'll wonder why it's low calcium, since it seems like it should be high calcium that causes cramping. If calcium causes muscle contraction, then you'd think high calcium would cause cramping, but it's actually more complex than that. In any case, you kind of want to get these things because if you're having muscle cramps, you wake up in the morning and you have that cramp in your neck. If you understand electrolytes, you know what you need to do is consume some calcium, or later we'll talk about how you can also get your calcium up with acid or potassium. The next question is, what specific ion channels contribute to AR action potentials? I should be careful, again, I said this before, because there's several different potassium channels, and we're in a general sense talking about potassium channels as a group of potassium channels. But we'll talk about them generally as voltage-dependent potassium channels again. So in AR cells, we have 2 voltage-dependent channels, a fast calcium channel, and I indicate a voltage-dependent channel, again, by showing that gate with the positive charges. And a voltage-dependent potassium channel is in here too, again shown with this gate with the positive charges. Fast calcium channels open at negative 40 millivolts, and they only stay open for a short period of time, which is different than the calcium channels in CM cells, which again were called slow because they stay open for a long time. Voltage-dependent potassium channels in AR cells open at around 0 millivolts. Also, AR cells have small sodium leak channels that always allow sodium to leak into the cell, and it's going to cause a constant slow depolarization of the cells. So 3 types of channels in AR action potentials. So let's start with where we ended that last slide with that sodium leak. So as sodium leaks through the sodium leak channel, a positive ion is flowing into the cell, and that's going to raise our voltage slowly. When we get up to negative 40 millivolts, a voltage-dependent calcium channel opens. So what I have drawn here are the 3 different channels and their states here, their states here, and their states at the top of the action potential. So at the beginning, we only have the sodium leak open, the voltage-dependent calcium and the voltage-dependent potassium are closed. When we get to negative 40 millivolts, the voltage-dependent calcium channel opens, calcium enters the cell, and that raises our voltage even faster. Again, that's because there's more calcium on the outside of the cell, so when calcium channels open, calcium flow into the cell carrying its positive charge. That means the VM will go more positive. At around 0 millivolts, the voltage-dependent potassium channel is open, potassium leaves the cell, and voltage returns to negative 60. The cycle then begins again because those sodium leak channels are still open. So if we look at another figure, we see that the orange represents sodium leaking into the cell to raise VM. The red line then shows calcium entering when we get to negative 40 millivolts, and that raises our voltage up to somewhere between 0 and plus 20. At around plus 20 or 0, somewhere in there, the voltage-dependent potassium channel is open, potassium leaves the cell, and brings our voltage back down to 0. Increasing sodium concentration will do what? It will cause more sodium to leak into the AR cell. It's going to shorten the orange line. This is going to climb faster. So cause more sodium to leak into the AR cell, shorten up the action potential, and thus increasing heart rate. So B. Just as a quick preview, notice how the CM action potential looks quite a bit different than it did in the AR. The main difference are those slow calcium channels. So in CM cells, VM rests at around negative 90 millivolts. There are 3 general types of ion channels. There are voltage-dependent sodium channels that open at around minus 55. There's slow calcium channels that open at plus 30. And there's voltage-dependent potassium channels that open at plus 30. Again, all 3 have that little positively charged gate to indicate that these are voltage-dependent channels. The first question might be, if the CM rests at negative 90 millivolts and the voltage-dependent sodium channels don't open until minus 55 millivolts, how does the voltage get from negative 90 millivolts to negative 55? When we did this in neurons, the way we got to minus 55 in the axon hillock to kick off voltage-dependent ion channels that would start action potentials in neurons were that ions came down from the dendrites to the axon hillock and activated those voltage-dependent channels. In cardiac muscle, the answer is that sodium and calcium leak over from adjacent cells, which that adjacent cell may be an AR cell or another cardiac muscle cell. So if this cell over here is undergoing an action potential and sodium and calcium are coming into this cell, they will leak over through gap junctions between the cardiac cells, and now this cell will be activated by the calcium and sodium that leaked over and are depolarizing this cell. So let's break up the action potential now that we're at negative 55 millivolts. Once the CM cell is at negative 55 millivolts, the voltage-dependent sodium channel is open. So same structure here where there's 3 main channels, and we're going to pay attention to 4 different locations. Rest, at the beginning of the plateau, at the end of the plateau, and as we're repolarizing. So once the CM gets to minus 55, the voltage-dependent sodium channel is open. Sodium rushes into the cell and makes the cell more positive. So that causes this rather large depolarization. At plus 30 millivolts, both the slow calcium and the voltage-dependent potassium channel is open. Calcium rushes into the cell as potassium leaves. Since positive charges are entering and exiting, VM stays about the same at plateaus. Every time a calcium cell comes in, a potassium cell leaves, and so the charge or the voltage is balanced, and the voltage isn't changing much, so that causes a plateau. In this plateau, when calcium is entering, it's binding to troponin and causing it to move aside so that the muscle can contract. After about 125, sometimes 180 milliseconds, depending on the source, the slow calcium channels close. Now the only ions that are flowing are the potassium ions. Potassium is leaving the cell, and that's repolarizing the cell, which returns us back to rest. When we're in rest, all 3 channels are closed, and we're waiting for sodium and calcium to come over from an adjacent cell again to activate the voltage-dependent sodium channels. Here's just another view of the underlying ion flows. The potassium one looks a little bit odd because by convention it's drawn upside down to indicate that potassium is leaving the cell rather than entering the cell. So an upward deflection means an ion is coming into a cell. Downward deflection means the ion is leaving the cell. So since sodium and calcium are entering the cell and raising voltage, the ion flows show an upward deflection. When potassium channels are open, they cause a downward deflection as they reduce voltage. The main line that you need to be able to understand, though, is the green line, because that's the actual cardiac muscle action potential. Depolarization phase of the cardiac muscle action potential occurs when, so here's depolarization, that's due to sodium channels. So voltage gated sodium channels are open. The answer here is C. We can do these when we do learning catalytics, but I also don't necessarily want to give away the answers yet. I have a bit of a typo here, because what I mean to say is in AR cells, calcium is responsible for depolarization, while in muscle cells, it's necessary to initiate muscle contraction. So the calcium entry in AR cells sets timing, but in the cardiac muscle, that calcium is actually binding to troponin, causing muscle contraction. Thus, if we could control either calcium concentrations or the flow of calcium through ion channels, we could alter how fast the heart beats, that's true, or how hard the heart beats, that's true. When we have a drug that affects heart rate, it's called a chronotropic drug. When we have a drug that affects heart contractility, it's called inotropic. Blocking calcium channels in AR cells, that would slow down the red, and it would stretch out this action potential, so it would slow down heart rate. That's a negative chronotropic drug, so I like B here. Blocking calcium channels in heart muscle cells would remove the ability of calcium to cause contraction. That would decrease the strength of contraction, and that's called a negative inotropic drug. That answer is at D. If the body wanted to speed up both heart rate and increase contractility, it could. Well, if you wanted to speed things up, you would speed up sodium by stimulating sodium channels. But I like that answer, but it doesn't really affect contractility because this is already pretty fast. So speeding up sodium doesn't really increase contractility too much. Here, we could speed up calcium. That's not really going to speed up the heart rate too much, but that would increase contraction. If we stimulate potassium channels, this is going to come down faster. It's also going to cause more potassium to leave the cell, which is going to allow more calcium to come into the cell during the plateau, and that would increase contraction. So probably the best answer, in the NCLEX test or a lot of boards exams, there might be multiple right answers, but you have to find the best answer or the best right answer. The best right answer here is to stimulate potassium channels. If you stimulate potassium channels, the blue line comes down faster and you go through the action potential faster. In the cardiac muscle, remember, potassium and calcium are linked or they're coupled together. So if more potassium is allowed to exit the cell, more calcium comes into the cell. More calcium into the cell would increase contractility. Chemical in the body that does speed up both heart rate and increases contractility. Here I'm just asking you to make a good guess. Serotonin affects sleep, thyroxine affects metabolism, growth hormone affects growth. So you could get to the last right answer by just thinking, well, I'm going to eliminate the ones that clearly don't do anything to the heart. But also you could jump right to adrenaline, because most of us know that adrenaline is a stress hormone that speeds up the heart and increases contractility of muscle. So the answer here is adrenaline. Because we can inhibit this substance, we can pharmacologically slow heart rate and relax contractility with, some of you might know this, but beta blockers actually slow heart rate and relax contractility. It's the way to slow down a heart that's working too hard or heart that's working so hard that it causes pain. It's a way to calm the heart down before it causes itself pain, which is called angina. I like bringing this up about beta blockers is at one point we thought the mechanism was one way. We thought what it did was inhibited potassium channels. Turns out that it's more likely that it inhibits calcium channels, which is interesting in and of itself because a lot of times we don't understand the mechanism of the pharmaceuticals we give, or we're making a good guess but we don't know exactly. And if you think about it, if you inhibit potassium channels or inhibit calcium channels, both of those are going to slow down heart rate and slow down contractility. So some of the old textbooks thought that it basically inhibited potassium channels. It's more likely now that it inhibits calcium channels. I go with a potassium channel angle still because it's a little bit easier to see that if you have a beta blocker, it slows down the ability of potassium to leave the cell, and that stretches out the action potential and slows down heart rate. Also, if you slow down the ability of potassium to leave the cell, since potassium and calcium are linked, it's harder for calcium to come into the cell. If less calcium can come into the cell, there's not as much calcium to cause muscle contraction, and you get less contractility. So I like the old definition that beta blockers inhibit potassium channels, but it's much more likely these days that what it actually does is inhibits calcium channels. And we don't even know yet that that's the right answer. There are videos of these drawings that you can do. And this is kind of just for those that really want to push themselves. It's a bit of an oversimplification, but can you work through, okay, I'm going to inhibit sodium channels, I'm going to stimulate sodium channels. What would that do to the arrhythmic cell? What would it do to the cardiac muscle cell? And what would it do to the EKG? Coming back still in heart muscle, now we're going to talk about cardiac output. So this will be a topic that will come up over and over. We're talking about what controls or affects how much blood the heart pumps. Just as with action potentials, diet, drugs, and fluid levels can have significant effects on cardiac output. We'll draw this out on the board as well, and there's a video on YouTube of it, but I'll also talk through it here to give you a slightly different storyline that you can hear twice. Cardiac output is essentially expressed in liters per minute or milliliters per minute, so it's the amount of blood pumped per minute. Cardiac output is dependent on heart rate, so how fast the heart beats, and stroke volume, which is how much the heart pumps per beat. So heart rate is how fast the heart is beating and is measured in the number of beats per minute. Stroke volume is the amount of blood pumped per beat and is usually expressed in milliliters per beat. When you multiply those together, you get milliliters per minute or liters per minute. That's the unit of cardiac output. So cardiac output becomes the product of heart rate times stroke volume. If heart rate is usually 75 beats per minute and stroke volume is usually around 60 to 70 milliliters per beat, then cardiac output is usually around 5.35 liters. I kind of rounded a little bit there, or we could say heart rate is 70 beats per minute, stroke volume is 70 milliliters per beat. That's about 4.9 liters per minute. So it's right in that range of a little over 5 liters per minute. That's kind of an interesting number because that's about how much blood you have. So you pump your whole volume of blood once a minute. Obviously, we can measure heart rate pretty easily, but it's a lot more difficult to measure stroke volume. We measure heart rate by that's simply your pulse. Stroke volume is equal to EDV minus ESV. Now these are tricky terms, or they're tricky for me. I always have to think through them. EDV is end diastolic volume. Diastolic means rest. So the volume of blood in the heart at rest, when it's ending its rest and when it's just about to pump. So it's when it's the fullest because the heart is ending its rest and getting ready to contract. ESV is end systolic volume, so the volume of blood in the heart after a contraction, which is when it's the emptiest because it's ending its contraction and getting ready to rest. So stroke volume is EDV minus ESV. From this portion of the Wiggers diagram, we can see that EDV is typically around 130 milliliters per beat. ESV and systolic volume is usually around 50 to 60 milliliters per beat. This gives us a stroke volume of around 70 milliliters per beat. I should mention that that's an interesting number too, because it also means that you still have 50 milliliters of blood in the heart after it's contracted. I think if we thought about it, most of the time the body is very efficient, and if it's going to do something, it does it 100%. We kind of have in our mind that when the heart contracts, it pushes out all the blood, but it pushes out about 60% of the blood. That's called the ejection fraction. It turns out it's kind of an interesting number because if you give certain chemotherapeutic drugs, you need to make sure that the heart can clear blood well and that blood won't sit in the heart. Otherwise, you have this toxic substance sitting in the heart, killing the heart muscle. So ejection fraction is kind of an interesting number. We'll draw this out a bit more on the board, so our figures might look a little different from these, but just as an introduction, the autonomic nervous system affects heart rate. And that's the main controller of heart rate. There's several things that affect stroke volume. We're going to break it down into something called preload, afterload, and contractility. This figure is nice because it starts to break things down even more. Again, the main determinants of HR, or heart rate, are the outputs of the sympathetic and parasympathetic nervous system. The three main things that influence stroke volume, again, are preload, contractility, and afterload. And then when we draw this out on the board, we'll clarify what are these other factors a little bit more clearly, I hope. So I don't think I'll go through all of this in this video, because this video is already going to be long enough. I would refer you over to the other video on cardiac output to listen and hear about cardiac output, the factors that affect cardiac output. And that video is on YouTube under cardiac output. Increased venous return to the heart causes it's going to increase preload. And we know that preload affects stroke volume. And we know that stroke volume affects cardiac output. And preload is how hard the heart contracts. So I like E, all of these. If the left ventricle begins to pump a higher volume than the right, it can't really happen because it's one continuous loop, or it can't happen for long. And what does happen, if one side of the heart gets ahead of the other side, contractility will increase because one side will see more blood, and that will preload that side of the heart to get it to contract that extra blood more, bringing the heart back into sequence or synchronicity. While preload can be beneficial in hemorrhage, its effect on a decrease in blood pressure due to edema is, problem with preload is if there's less blood to pump, the heart pumps less, which means if you're slowly bleeding, that can be a good thing for hemorrhage, because it means with hemorrhage you have less blood, the heart's going to pump weaker, and you're going to bleed to death slower. But if you have a blood loss due to edema, it means you already don't have enough blood to circulate, and the heart is not going to pump as much blood. So it could result in a positive feedback cycle where there's lower and lower pressure from the heart that's causing more and more fluid to leak out of the blood vessels. So there's less blood to pump, and the heart is pumping less. Next, we're on to the conduction cycle. So we've been building up this section as we covered muscle, AR cells, cardiac muscle cells, and action potential. Next, we'll do the conduction system. So we're going to look at the electricity as it goes through the heart. It seems like a relatively easy thing to cover, but it can get quite complex because we watch the conduction system when taking an EKG. I often say EKG because EKG rolls off the tongue. The technical term is ECG, but the old Latin for cardio began with a K, and so EKG means the same thing as ECG. Usually when you write something down, you write ECG, but EKG kind of rolls off the tongue a little bit more. It's probably also like the mitral valve, where the older term is EKG, so newer people in the field will probably call it ECG more often than EKG. A beautiful thing about the EKG is Einthoven discovered it about 130 years ago, and in that 130 so years since the ECG was invented, we figured out a lot of things that can change in the heart and the conduction system. Tiny little change in the blip here, tiny little change here, tiny little bit too high here, too low here, can indicate where a problem is occurring in the heart. Too little blood flow, problem with the conduction cycle, all scar tissue, all kinds of things can be diagnosed with an EKG. So we've used these terms already, but we'll hit them again. Kind of had to introduce them when we did ESV and EDV. But systole is when the heart is contracting, and diastole is when the heart is relaxed. I'm going to do the cardiac cycle first. So the cardiac cycle is what is the sequence of events that the conduction system takes the heart through in contracting. So just like squeezing toothpaste out of the tube or milking a cow, I did it once. The squeeze of the heart needs to be in just the right order. So the heart needs to pump in a precise sequence to maximize cardiac output. The atria contract and squeeze blood into the ventricles to increase their preload, because that's going to increase cardiac output. Then the ventricles need to squeeze superiorly, so towards the top, from the bottom to the top, to push blood out of the aorta and pulmonary trunk. So we can kind of see it in this figure that we need to activate the atria from the top down. We then need to sneak down the middle of the heart, called the septum, go up the sides of the heart, so we push blood up from the bottom side of the heart to the top to push it out of the great vessels. Everything begins in the synatrial node, or the SA node, which generates impulses about 75 times per minute. The signal passes over the atria, shown here by the purple coloring. The signal is also picked up by the AV node, this little yellow bulb here. The AV node delays the impulse approximately 1/10 of a second to allow the atria to contract completely and preload the ventricles. From there, the impulse passes down from atria to the ventricles via the atrioventricular bundle, or the bundle of His. Moving on, the signal passes into the bundle branches, here in purple, which carry the impulse towards the apex of the heart. You may have heard of bundle branch blocks as a type of cardiac arrest or disruption of the electrical system. Finally, Purkinje fibers carry the impulse the rest of the way to the apex, and then up the sides of the heart, up the sides of the ventricular walls, and around the back of the heart, shown here. So one thing to note is that most of the conduction system is on the inside of the heart towards the back. Knowing what you know about the path of blood flow to the heart, so remember that blood comes out the front of the heart and goes around to the back through the right coronary artery and the circumflex. And also remember that blood flows from out to in. That's a problem for the conduction cycle because it's often the last place to get blood. So the SA node is high on the back of the atria, and it's one of the last places to get blood, as well as the AV node. Often you can see a slight disruption in blood flow to the SA node and the AV node by a change in the timing of the EKG that tells you that a problem is developing. So essentially, if you're having problems getting blood flow to the AV node, you might pick that up on the EKG before you see further consequences of a decrease in blood flow that might damage ventricular wall muscle in a heart attack. So you can pick up slight changes in blood flow and head that problem off before you get major changes or major problems. So choose the correct sequence of current flow through the heart wall so we can immediately eliminate everything but B and E. I don't really like SA node to Purkinje fibers because I know that I'm going to go through the AV node next, so that's how I'm going to eliminate B. I like E, SA node, AV bundle of His, bundle branches, Purkinje fibers. When you take tests in AP2, it's the time to get better at multiple choice. And one of the ways to get better is to find out why each answer is wrong first, and then confirm that the one answer that's left over is the right answer. So answer the question to yourself both ways. Find the wrong answers, also find the right answer. We'll now extend our knowledge of the conduction system to how it's interpreted with an ECG or electrocardiogram. Again, that's often called an EKG because it just kind of rolls off the tongue better. So just as a quick look, we put electrodes surrounding the heart, and it doesn't really matter where we put them in the sense that the leads can just be placed on the arms and still pick up the electrical activity of the heart. Or the leads can be placed on the chest around the heart to reduce the electrical noise from things like muscle contraction or breathing or moving the arms and legs. It's guessed that Einthoven, the guy that invented the EKG, was labeling all the electricity he could find or electrical activity he could find in the body, and he began with A. When he got to the heart conduction cycle, he was at P, so he started with the P wave, which represents atrial depolarization and repolarization. The QRS represents ventricular depolarization, and the T wave represents ventricular repolarization. It's often taught that repolarization of the atria is masked by the QRS, but it's a little of both. Atrial repolarization takes place down the P wave as well as behind the QRS. Here's a figure that lines up the events in the heart with the EKG. So atrial contraction, or electricity going across the atria to cause contraction, begins the P wave. The QRS is defined by electricity going down the bundle branches and up the sides of the heart for ventricular contraction, and the T wave represents ventricular repolarization. And here's just a close-up where we have the P, the QRS, and the T. We can keep the ECG pretty simple. That's the way we're going to do it in lecture. Simple means to just identify the major waves and be able to spot a major departure from a normal EKG, so abnormal P waves or abnormal QRSs or too many P waves. The EKG can be so beautifully complex, and it isn't really that hard to get it. You just need to know three pieces of the puzzle. You need to know the conduction cycle, you need to know the different leads that pick up the conduction cycle, and know that the leads are a bit unique in how they pick up the conduction cycle. We'll do this in lab, and I'll lecture it through here once I've done the simple method. I would encourage you to try to understand 12-lead EKG because there's great comfort in kind of figuring it out. Also, it's just one of those simple puzzles that it's 3 pieces of the puzzle and it seems impossible to get them to work, but once it clicks, you really do feel pretty brilliant. The simple method is not entirely accurate, but it's close enough. It's close enough to get an idea of how the EKG works. There are 2 rules, but we'll look at them next to figures. So currents that are going down the heart will cause the EKG trace to go up. So as the current goes down the septum, down the bundle branches, it'll cause an upward deflection, shown here in orange, on the EKG. As electricity goes up the heart, as in up the Purkinje and up the walls of the ventricle, if it's going up the heart, it goes down on the EKG, shown here in yellow. That's one rule. The other rule is all currents go in both directions because the EKG picks up the voltage change of both depolarization and repolarization. What that means is as the voltage signal leaves the SA node, it passes down the atria. So this is going to cause an upward deflection on the EKG because a current down the heart goes up on the EKG. Bringing in the second rule, if you have a current down the heart in depolarization, you have to have a current back up the heart in repolarization. So when the atria repolarize, the voltage is changing in the opposite direction, so we can think about it as going up the atria. Since the current going up causes a downward deflection, the P wave returns to baseline. Again, I always have some students that have been taught an EKG, and typically it's taught that repolarization of the atria happens behind the QRS, and so it's lost. I include this figure because of that, and it shows that many parts of the atria, so atria is beginning to depolarize here and repolarize, and shown in green, it definitely occurs in part of the P wave as well. I think it's a little bit more accurate to describe it this way, and it certainly makes a little bit more sense the way I describe it. It doesn't really matter. It's just what I'm going to do is say that depolarization takes us up the P wave and repolarization takes us down the P wave. As the signal goes down the septum, this causes an upward deflection on the EKG. Now we have a large current up the heart, and so this causes a downward deflection. Lastly, we have repolarization of the heart. It's a little bit cryptic, but mainly it's a voltage that's going up the heart. Technically, because it comes around the back of the heart, it goes up and down. So for now, in the simple method, we'll just say that repolarization of the ventricle causes an upward and downward deflection that causes the T wave. So the T wave is repolarization of the heart. We can put them all together to get the P, QRS, and T. Atrial depolarization, atrial repolarization, down the septum, up the sides of the heart, and then repolarization as the T wave. So that's the simple EKG. To do 12-lead, and I would wager that we're all going to look at an EKG that matters to us someday. Could be yours, it could be a family member's, could be husband, spouse, whatever. There's comfort in having a little bit of knowledge of 12-lead EKG. Also, it's a pretty good example of the beauty of clinical testing because Einthoven stuck his hands in buckets of salt water, saw the electricity with a galvanometer. So for the next 130 years, we've been analyzing how changes in that signal indicate heart function and pathology. And we still don't know it all. We still don't really get repolarization. There's much to learn about EKG. EKG is also an example of something that can be simplified with simple rules. And then applying those simple rules makes things look pretty complex. But as long as you take it back to the simple rules, it's always going to work. Hey, what? Stop making so much noise. I would also argue, lastly, that EKGs are getting cheaper and cheaper. So if you go to a doctor's office, or at least I do, you'll still get a 12-lead EKG, whereas 10 years ago, you'd get maybe a lead 2 EKG. So I think you're going to see more and more 12-lead EKG and less just simple 2-lead. So it's good to understand the whole EKG and not just the simple P, QRS, and T that you see in lead 2 EKGs. This was once a really good website, this Blaufus. It had really good animations. It showed animations that were happening in the heart and how it changed the EKG. I keep leaving it in because I'm hoping that it comes back, and someday I'll go to that link and it will be reestablished with more current multimedia functions. So I will lecture through this and listen loud. Because I feel like sometimes it's just good to be able to listen to things multiple times. So I'm going to go ahead and describe it here as well too. But it's going to be better in lab when we actually can stand over a diagram and draw on it. The first thing is there's 3 rules you need to get to understand 12-lead EKG. The first is to know the conduction system. So atrial depolarization, atrial repolarization. Technically, we have to add something called septal depolarization, apical depolarization, ventricular depolarization, late left ventricular depolarization, and then ventricular repolarization. So that's the conduction cycle. We then need to know the leads. The leads are what allow us to see those voltage changes. The last thing is that the leads see voltage changes according to some rules, and once you understand those rules and you put all 3 of those pieces of the puzzle, 12-lead EKG is really not that complex. Simply put again then, there are 3 pieces of the puzzle, or 3 rules to get to work together to understand 12-lead EKG. Those are, what are the voltage changes that occur in the conduction cycle? What are the leads used to pick up the voltage channels? And how do those leads specifically report the voltage changes? The conduction system, as I mentioned before, is slightly changed. We have depolarization and then repolarization of the atria. The signal pauses in the AV node for 1/10 of a second, and that's the delay between the P and the Q. Then current heads down the septum, and it goes down the right slightly before the left, leading to a direction in the voltage that leads to something called septal depolarization. So the voltage is actually headed towards the right. Next is apical depolarization, because the apex of the heart is depolarizing. Then the voltage spreads up the left and the right sides of the heart. Because the left side has so much more muscle, most of the voltage goes up the left side of the heart versus the right side of the heart. We then finish depolarization of the ventricles as the electricity goes around to the back of the heart, and then we finally finish up with ventricular repolarization. So these are the 6 steps in the conduction cycle that will follow in the 12-lead EKG. Again, we catch both repolarization and depolarization because the EKG picks up both of those voltage changes of depolarization and repolarization. We'll get into this in a second, but leads can only see voltage changes that run parallel to the lead. It's a bit like it's hard to tell how fast something is moving if it's coming right at us, if it's coming straight at us, but it's easier to see the speed of something that's going across our field of vision. So, since a lead can really only see voltage changes running parallel to the lead, and since the electrical changes go in multiple directions, it's nice to have multiple looks or multiple leads to look at the different voltage changes from many angles. The main leads are lead 1, which is from the right shoulder to the left shoulder, lead 2, which is from the right shoulder to the left leg, or right arm to the left leg, and lead 3, which goes from the left arm to the left leg. Those are the typical 3 leads. Most of the voltage goes from the right arm in the direction of the right arm towards the left leg, so that's why lead 2 is usually the best lead to pick up the majority of the events in the EKG. Sometimes we like to shift this triangle a little bit, and those are what the green lines are. Those are called the augmented leads, and that just shifts the angle a little bit. Notice that it splits the angle, and so it has 3 more angles to look at in the frontal plane of the voltage going through the heart. Leads 1, 2, and 3 and the augmented leads, again, look at voltage changes in the frontal plane. It's also nice to see voltage go from front to back in the transverse plane. So 6 more leads, called the precordial leads, or the V leads, are used to see voltage changes from front to back. These electrodes are placed across the chest and under the armpit to see the voltage go from front to back. That's how we get to 12 leads. 1, 2, 3, 3 augmented leads, plus 6 precordial leads gives us the 12-lead EKG. The last rule, or piece of the puzzle, is to come back to how leads see the conduction cycle. We mentioned that a lead will only pick up a voltage change if it's running parallel to the lead. More specifically, the lead will pick up the part of the voltage change, or the lead change, that is running parallel. So the lead may still pick up part of a voltage change if it's not running exactly parallel to the lead. One last thing to note is that leads have a direction, as shown by the arrow So there's an arrow here. If a voltage change is moving in the same direction as a lead, the EKG will show an upward deflection. If a voltage changes in the opposite direction of the lead, then the EKG will show a negative or downward deflection. Here's a nice figure that kind of illustrates that even more. It shows how the lead will pick up voltage changes based on the direction of the voltage change. In the first two panels, the voltage change is in the direction of the lead. So again, lead 2 goes from the right arm to the left leg. These voltage changes are going in the same direction, so we see a positive deflection. Also, note part 2 of that rule is that a lead will only pick up the part of the voltage change that's parallel. Notice that this first panel shows a voltage change that's very parallel to the lead, but this heart shows a voltage change that's less parallel to the direction of the lead. So we see a less positive upward deflection here because it's not as parallel to the lead. If the voltage change is perpendicular to lead 2, the lead can't pick up the voltage change, and we get what's called an isoelectric lead, which means there's the same amount of voltage up and down, or the voltage essentially stays flat. In the fourth and fifth heart here, the voltage is in the opposite direction of the lead. So again, the lead goes from right arm to left leg. These voltage changes are going towards the right arm, so we get negative deflections. The same rule applies here, that if the voltage change is very parallel to the lead, we get a bigger deflection than if it's not quite as parallel. So really nice figure to show how the direction of the lead and how parallel the voltage change is to the lead tells us how big of an upward or downward deflection we're going to get on the EKG. And that's the third piece of the puzzle. Now we can step through the steps in the conduction cycle and see how the leads will pick them up. In an EKG, the leads can't track all voltage changes. It kind of sums them up. So in atrial depolarization, we have voltage going all across the atria, but the EKG sums it up into one voltage called a voltage vector. In lead 2, the voltage is parallel to the lead. It's in the direction of the lead, so we get an upward deflection. Note that in lead 1, it's not as parallel, and so we get an upward deflection. It's kind of upside down here, so look at it from the top. This is an upward deflection, but it's not as big as in lead 2. That's kind of a curious thing, because if we got a situation where we had more muscle over here, say the mitral valve was sticky, and so the muscle has to get thicker in order to get the blood through the mitral valve, we might shift this vector of apical depolarization in this direction, and that would increase the size of the P wave in lead 1 over lead 2. So that's a simple diagnostic of too much muscle in the left atrium if all of a sudden the P wave is larger in lead 1 versus lead 2. Try to apply these rules to why the P wave is pretty small in lead 3. The main reason is because the voltage is going towards lead 3. This is lead 3. The voltage change is perpendicular. It doesn't see the voltage change very well, so the P wave is often the smallest in lead 3. We then repolarize the atria and the P wave returns to baseline. We're also going to have a pause here, you'll see it in the next panel, where the signal is held in the AV node for 1/10 of a second, and that's the duration between the P and the Q. The current then goes down the septum, and septal depolarization is pretty perpendicular to lead 2, so the Q is pretty small in lead 2. Septal depolarization runs in the opposite direction of lead 1. It's pretty parallel, so we usually get a larger Q in lead 1 than we do in lead 2. In lead 3, septal depolarization is going in the same direction of our lead, but it's pretty perpendicular, so we get a small Q that's upward in lead 3. Next, we have apical depolarization, so current heads down to the apex and splits to go up the left and the right. Recall that the EKG doesn't pick up all voltage changes, it adds them all up. Since more current goes up the left, apical depolarization points to the left. This can be a very informative voltage because if it shifts to the left or right over time, it means the amount of muscle in the heart is changing. Muscle can change due to death or hypertrophy, which is extra growth. In lab, we'll talk about apical depolarization in terms of the clinical measure called the QRS axis. Since apical depolarization is down the heart and parallel to lead 2 has a large upward deflection that takes us to the top of the R wave. Apical depolarization runs the same direction of lead 1, but it's a little bit more perpendicular to lead 1 than lead 2, so our R wave is typically smaller in lead 1. Apical depolarization runs perpendicular to lead 3, but it does run in the same direction, so we get an upward deflection, though it's not a very big upward deflection. The current now continues up the sides of the heart, so shown here with this purple. This is called late left ventricular depolarization. Since the current is running in the opposite direction of lead 2, so we're going in this direction, it runs in the opposite direction of lead 2, which means we get a negative deflection. So this takes us from the R down to the S. For all of these, can you see how the leads will pick up these voltage changes by applying our rules? Trying to get you to start to think these through yourself. So the first thing here is this is very perpendicular, and so it won't be picked up by lead 1, but it then does run in the opposite direction of lead 1, so we get a negative deflection in lead 1. It's pretty tricky in lead 3. We run the opposite direction of our lead, but by the time it goes around the back of the heart, the pathway starts to run in the same direction as lead 3, so we get a downward deflection and an upward deflection in lead 3. There's some disagreement about how repolarization occurs, and honestly I've read it both ways, and that's why on my drawing it's both ways. It doesn't really matter for the understanding of EKG, but this is why I have my yellow arrow in different directions. Different sources have led me down different pathways. At the beginning of the current, it's running very perpendicular to lead 2, so we don't see anything. Then it runs with our lead, so we go up, turns around and goes back against our lead, so that's why we get a T wave that goes up and down. Here's the up part of the T wave, and here's the down part of the T wave. Notice that in lead 1 we get the same basic thing. We run with our lead, we're then perpendicular, and then we're against it. So with our lead, perpendicular, and then against it. Lead 3 has a really kind of a weird T wave. It's running against our lead, so we go down on our T wave. Then it runs with our lead, so it goes up on our T wave. And then it runs perpendicular, so we don't see anything. So this is why we get an inverted T wave in lead 3. We should have an inverted T wave in lead 3. An inverted T wave in leads 1 or 2 is usually a sign of a problem. So we're going to do all of this in lab, but I think by talking this through multiple ways, maybe it will click in. Again, it's really just applying the 3 rules of what's the conduction cycle, what are the leads, and how do the leads pick up the conduction cycle. When it clicks, you'll feel that you can read EKGs pretty well, and you'll be able to read, you won't be an expert, and you won't be able to read the complex things, but you'll have a good foundation to extend on it if you think you might be interested in working on a cardiac floor. Or again, a third of us are going to die of cardiac disease or heart disease, so most of us are probably going to see an EKG that matters someday. If you put some work into 12 lead, it's going to get easier and easier. And again, it's going to make you feel quite brilliant. And as I said, I think we'll all look at EKGs that matter to us. You can even buy an EKG machine now for $2,000. Or I have a little one that sticks on the back of your phone for $100 that'll give you a lead 1 EKG. So that's 12 lead. I'm going to flip back to lecture, and I'll talk about this in lab too. An expectation in lecture is that you can spot an abnormal EKG. So on the lecture test, you'll need to be able to spot an abnormal EKG, where abnormal means it does not follow the usual pattern of P, QRS, and T. So for example, there are way too many P waves in this trace. So I see a P wave, QRS, T, maybe that's a T, maybe this is the T, but even if this is the T, I see 2 P waves. What's happening here is the atria are contracting too fast. You're getting multiple atria contractions per ventricular contractions, so you're seeing multiple P waves. When the heart beats too fast, or when the heart contracts too fast like this, it's called flutter. When it's completely uncoordinated, it's called fibrillation. So this is atrial flutter because the atria are contracting too fast. On this one, the P wave's too long. The EKG is picking up the signal that's not stopping at the atrium, but is going into the ventricle. This is called Wolff-Parkinson-White, where some of the signal from the atria leaks down into the ventricle. If you look really close, this creates a normal P wave, because this is normal atrial contraction, and that's the P wave right here. This signal is very long and goes all the way down into the ventricle, so we get kind of two P waves. We get a very long P wave here. So you're seeing two different P waves, a short one and a long one. Here you don't see a QRS, so this ventricle is in fibrillation. This person is in cardiac arrest. During the QT interval of the EKG, so between Q and T, that's the beginning of ventricular depolarization, and the T wave is ventricular repolarization, so the ventricles contract and are beginning to relax. So C. An enlarged R wave, it's not a good diagnostic because the size of the waves in an EKG can depend highly on how hydrated you are or how much subcutaneous fat. Anything that gets in the way of the electrical signal getting from the heart to the electrode can increase or decrease the size of the R wave. So it's not a big diagnostic. If it was huge, though, it would indicate that there's a lot of muscle, which is causing a really large R wave. And so this could be caused by an enlarged ventricle, or A. Which interval is more likely to change often? A bit of a tricky question. The biggest interval is this is one heartbeat. Your heart rate goes up and down, so the biggest interval that's going to change is from T until the next P, because that's going to lengthen when the heart rate goes down and shorten when the heart rate goes up. So the answer here would have been C. We have one last thing that we have to cover in the heart, and that's cardiac cycle. Well, technically two things, because we're going to go back out and do congestive heart failure, but one last major thing, which is cardiac cycle. And this is described really well in something called the Wiggers diagram. So we're finally going to come back to this Wiggers diagram that we've been talking about and put it all together. So at the bottom are the major stages of the heart. So let's look at this figure at the bottom. This figure is from OpenStax, which is just an free online textbook. So the first thing is ventricular filling. Blood is coming through the atria and going into the ventricles. This first part is pretty passive. The atria are not doing anything. Then we have atrial contraction, where the atria contract and shove more blood into the ventricles, and that adds about 20 more milliliters of blood to the ventricle, and it preloads them. Next, we have isovolumetric contraction. That's when the heart starts to contract. When blood hits the AV valves, so the ventricles start to contract, blood hits the AV valves, they close. The semilunar valves here are still closed because there's not enough pressure in the heart to push them open yet. When the semilunar valves open, we get ventricular ejection, and then as the heart starts to relax, blood wants to come back from the pulmonary trunk and from the aorta and enter back into the ventricles, so the semilunar valves close. All valves are closed again, so this is another isovolumetric stage. This one is called relaxation. So iso means same. Isovolumetric means the amount of volume of blood in the heart is not changing, it's staying the same. And that basically indicates that all the valves are closed. We have an isovolumetric contraction before the aortic and pulmonary semilunar valves open. And then we have another isovolumetric when they close and all the valves are closed again. We can line up those events with the EKG. I would say first thing that you want to do is memorize this sequence of events. So you see the major event in the conduction cycle. And then this is the base of the Wiggers diagram as well, because then with the Wiggers diagram, you can compare the physical states of the heart with other things like the EKG. So again, atrial contraction is going to line up with the P wave. Isovolumetric contraction is going to start at the Q. Ventricular ejection is the QRS. And then we're going to relax in isovolumetric relaxation, which will be out at the T wave. Let's step through the major things. So there's a whole lot of information that can be gathered from these figures. I would like you to first get the cardiac cycle, so the physical events that are happening in the cardiac cycle. Then compare the events in the cardiac cycle to the things shown in the Wiggers diagram. What are the various pressures of the ventricles? When are the valves opened and closed? What is the volume of the heart at various stages? And when do the heart sounds occur? It'll be fair on the lecture exam to ask you a question like, in what portion of the EKG is the volume of the ventricle the greatest? You'll hear me say this a lot. You can either be clever or you can be good. Good is to figure it out just by thinking it through. Clever is to use tools like the Wigger's diagram. So you can be good and know that the most blood is in the heart right before it contracts. The QRS goes through the heart just before contraction. So just after the QRS is when the heart is most full of blood. That's being good. You can also be clever and say, well, here the volume is the greatest. Let's line it up. Technically, here's when the volume is the greatest. Let's line it up with the EKG. The volume is greatest during the QRS. Since you're going into allied health also, being able to read visual representations of data on a chart will be an important skill. You have to visualize information. The Wigger's diagram is a good chart to practice on. Let's go through a few more things. Blood is flowing passively into the ventricles during ventricular filling. So notice here, let's line it up over here. Blood is flowing into the ventricles, so the volume of the ventricles are slowly increasing. There's no activity really in the heart because the heart is passive, and so the EKG shows nothing. Pressures are also really low too because there's not anything contracting. The atria contract here in atrial contraction. And that adds, if you look closely, we go from about 110 milliliters of blood to 130 milliliters of blood. So we add about 20 more milliliters of blood into the ventricles. This increases the preload, but it's a pretty small amount compared to just passive filling. That has some relevance. Two of the main places where that has relevance is if somebody's in atrial fibrillation or atrial flutter, it can descend into ventricular problems, but if it stays in the atria, it's not a huge emergency situation because even without the atria, the ventricles are filling pretty well. They're not getting that last 20 milliliters and they're not getting that preload, so they won't contract as hard, but they're still getting blood to pump. The other way that you see the effect of this is often when they put in artificial pacemakers, they don't put it where the natural pacemaker, the SA node is. They simply put it down in the right ventricle. When they put it in the right ventricle, it causes the ventricles to contract and push out blood. It just simplifies things. Why would you do that? Well, you avoid the complexity of atrial contraction, ventricular contraction, and you're still able to push out this amount of blood, even though you're not loading the ventricles quite as much. So atrial systole does contribute to the ventricles, but not in an absolutely necessary kind of way. Now we move to a very short time where all valves are closed. No blood is entering or leaving, so the volume is staying the same. This is called isovolumetric contraction because, again, iso means the same. So the heart has started to contract. It's going to close the AV valves, but it doesn't have enough pressure to open the semilunars. Once the pressure in the ventricle exceeds, and you'll actually see this crossing over, the pressure in the ventricles exceeds aortic pressure, now the semilunar valves are going to open and blood is going to be ejected from the heart. When the heart starts to relax, the pressure in the heart goes below the aortic pressure, and so now the semilunar valves close. There's kind of a neat little dip in the pressure here, where when the blood coming back and hits the semilunar valve, it kind of bulges the aortic a bit, as if like it's banged against the wall, it's banged against a door that's closed. It causes a bump in pressure called the dicrotic notch. Again, things to get from this chart are the atria are not really important because they only add a certain amount of blood to the heart. After a contraction, note this, after a contraction, we go from 130 milliliters down to 50 milliliters, so we didn't pump out all the blood. We've mentioned that before. That means if the heart contracts harder, it can contract more of that extra blood out of there, and you'll get more contractility and more cardiac outputs. Then again, compare events in the heart because it's fair to ask you things like pressure in the heart is greatest during what part of the EKG, pressure in the heart is lowest during what part of the EKG, volume of the heart is greatest in what part of the EKG, volume of the heart is lowest in what part of the EKG. The second heart sound occurs during what part of the EKG? The second heart sound occurs during high volume or low volume. So you'll want to be able to compare things just because you want to get better at seeing the visual information that can be relayed in a chart like the Wiggers diagram. Phase in the cardiac cycle in which the ventricles are completely closed and the volume of blood in them is constant is referred to as ISO. Probably should have rewrote that question, stole it from somebody. Probably should have rewrote that question because it could be C or D. Which brings up the point is if you have a question like this on a test, write out your argument on the test. I encourage you to write on tests because when we go over tests, I'll listen to those arguments and I may give you your point back if you make a pretty good argument or you make a legitimate argument. The end diastolic volume is end diastolic is rest, so this is the end of rest. Volume of blood, we know it's not A or B because we don't really pay attention to volumes in the atria, so we know it's C or D. Volume of blood in the ventricle at the end of rest, so relaxation, so D. The average end diastolic volume of the ventricle, if we were to go back to the Wiggers diagram, this was about 130 milliliters. Whereas the end systolic volume, different books use different things. Previous book used 70 milliliters. This book uses closer to 50. So we start at 130 and end at about 50. That's an interesting thing also because about at the end of passive ventricular filling, the ventricles are about 90% full. We don't need our atria. So this was B. At the end of what? The ventricles are 55% full. So at the end of systole, you still have about 55% of the blood left in the heart. More heart that you could pump out if you increase contractility. So the answer here was D. Again, hitting that point that you don't pump out all the blood on a pump. You only pump out about 45% of the blood. During the period of ejection, the left ventricular pressure reaches an average pressure of approximately, put the BP cuff there as a hint, usually systolic pressure, the high blood pressure in a blood pressure, is around 120 over 80 would be the diastolic, but the 120 represents the pressure the heart can push at, and so that's the answer, is E. So that's cardiac cycle. We're going to talk about EKG in lab extensively. In the first lab, I'd like you to go through and find different pathologies of the heart that can be picked up on EKG, like arrhythmias, hypertrophies, ischemias, pacemaker problems, carditis. Activation sequence disorders are like Wolff-Parkinson-White, where the electricity does not follow the normal conduction cycle. I'm going to try and add more of these things, but try to find pathologies associated with changes in the size, weight, and location of the heart. I had a student last year whose heart was flipped and upside down, and it changed the location of the heart. Dextrocardia is another example. She also had this. It was called crisscross heart, where the heart was upside down and twisted backwards. So dextrocardia means the heart is flipped. What are some of the cons of having two circulations in four chambers? What could be the advantages of having more circulations? Why not have a separate circulation for the brain versus everywhere else? Technically, the next best circulation in your body is your kidneys. Most of the blood leaving your heart right now is actually heading to your kidneys. Try and get a stethoscope and try and listen to different heart sounds. Things like that. Predict the consequences of either too much fluid or too little fluid in the pericardial sac. Too little fluid will cause more friction. Too much fluid is actually really interesting because when the heart contracts, if that space that it contracts suddenly fills in with fluid, when the heart goes to relax, it can't relax to the same big size again. And so fluid outside the heart, it's kind of like, I don't know if I should say it this way, but it's kind of like a python snake. Doesn't really squeeze, but when you breathe out, it squeezes so that you can't breathe back in. If you get fluid in the pericardial sac around the heart, when the heart goes to contract, if that space fills with fluid, then the heart can't open back up again, can't relax, and it can't fill with blood. So it's a pretty dangerous situation to have fluid around your heart. Explore the different types of CABG surgery. You're going to do cardiac drugs. We already talked about that. One last thing we should talk about, though, is CHF. CHF is congestive heart failure. We'll finish with congestive heart failure, which is something we talked about at the very beginning of this lecture when we talked about size, weight, and location of the heart, and we talked about hypertrophies and dilated hearts. Things cycle a lot in AP2, which is why you need to go over the material over and over and let it sink in and see more connections. And those connections will give you ahas that will push you to keep going and go, wow, this stuff is pretty cool. It is really cool. I really don't think you can cram AP also, because now you'll recognize too, if you're taking your time, that you'll see the beginning of CHF in something called QRS axis. So you want to take your time so your brain can make those connections. Congestive heart failure is weakening of the heart muscle. Can be caused by coronary atherosclerosis, so hardening of the arteries feeding the heart, persistent high blood pressure, multiple myocardial infarctions, which are heart attacks, and then dilated cardiomyopathy. If heart muscle is worked too hard, it grows thicker. Since the blood vessels are on the outside of the heart, thickening the muscle means the inside of the heart doesn't get as much blood, so the inside begins to die. This causes the heart to grow in size, but get thinner. CHF is a great condition to study early in AP because it causes problems in the heart, blood vessels, respiratory system, urinary system, and fluid and electrolytes, everything that we're going to talk about, or almost everything we're going to talk about in AP2. So take your time and think about this one at the beginning of AP2 because you're going to extend on it as we go through this semester. There's a video of this as well, but essentially there's a downward spiral where the heart fails to help itself. And that failure adds more stress to the heart and damages it further, causes this huge positive feedback cycle that causes a downward and downward cycle. So the heart can't pump enough blood. Less blood makes it back to the heart to be pumped. Less blood back to the heart means the heart muscle is malnourished. Malnourishment damages the heart muscle, so now the heart muscle is weak and dying, and now it's harder to even pump the same amount of blood, so you pump less blood. The kidneys, if the heart can't pump at high enough pressure, we'll talk about this when we get to the urinary system. I don't know if I mentioned it yet, but the urinary system is the most difficult system in AP2. If you can't pump blood at a high enough pressure, the kidneys can't get rid of fluid. That fluid kind of solves the blood pressure problem because now you have higher blood pressure because you've got more fluid. But it also means fluid is backing up everywhere in the body, including into the lungs. So the lungs fill with fluid due to edema. That means it's harder to load oxygen because some of the oxygen can't get into the blood because there's fluid in the way. So now you have less blood being pumped and there's less oxygen in the blood that is being pumped, which is going to cause malnourishment to the heart, which is going to kill more heart cells, which again, that's going to begin the cycle again of damage. So I like to put it in a downward cycle like this. This is a classic cluster mess, so we're going to have all kinds of cluster messes in AP2. So if the heart can't generate enough pressure for the kidneys to make urine, fluid builds up. That fluid enters the lungs. With fluid in the lungs, it's harder to pick up oxygen. So there's less oxygen in the blood, which leads to malnourishment. On top of that, you're having trouble pumping blood in the first place. So less blood to the heart cells causes poor cardiac output again. One last loop in here is if you can't pump blood, you can't pump blood through the lungs very well. When some of the blood goes through the lungs, it's not picking up oxygen because there's fluid in the way. So less blood is being pumped and there's less oxygen in that blood, which again leads to less nourishment to heart cells, heart tissue fails, and we begin the cycle again. Here's a photo of that dilated heart that we looked at earlier. So maybe go over the Wikipedia and read more on CHF. As again, CHF is a good one to study at the beginning of AP2. One of the things that I've noticed about Wikipedia in the last few years is 5 years ago it was all written really technical. The writing has gotten a lot better, and there's some areas of Wikipedia where I highly recommend you go and read. Things like edema, things like hematocrit. There's some areas where it's just like it makes you feel brilliant because it's been written so well now. So look up CHF. And then we'll have a case study on that as well. All right, so that's finally the most content. This is the most content-heavy section, but we're done with the heart for now. We'll do blood vessels next. Thank you.